Good evening, everybody. I hope everybody's well. Thanks so much for tuning in. I am Dr. Sam Shamardi, periodontist here in the city of Boston, coming to you tonight for our webinar talk on the topic of tissue grafting fundamentals and alternative options for the GP. Got a pretty tremendous amount to cover in just an hour. This could be a topic we could be talking for a good 3 to 4 hours alone. So I'm going to try and get the most important kind of essential facts for you in this short amount of time we have. And then I'll also take some time at the end to go over any questions that you might have. So without further ado, again, thanks so much for signing in. A big thank you, going back here, to our sponsors, Voco, for making this program possible tonight. Couldn't do that without them. And like I said, we'll get through everything and spend some time at the end. So as far as tonight's main topic of the tissue grafting fundamentals, our primary focus are going to be mucogingival deformities and defects. So going by the old perio classifications, of course, this seems to change every few years. I think the powers that be within perio are bored and don't have much better to do. But we really kind of focused on, in the classic classification, looking at this issue as a mucogingival deformity and defect. So the main things we're trying to do: define the primary forms of recession and mucogingival defects, assess those surgical options around teeth. But, I also wanted to throw in the importance of soft tissue for implant success and hopefully give everybody some new information and understanding of how essential soft tissue is for long-term implant success as well. And long story short, talk real briefly about some non-surgical treatment alternatives when treatment may either not be necessary or, from our patient standpoint, may not be desired, right? Not everybody wants to do a tissue graft of some form, so good to know what other great options that we have out there at our disposal. So, as I mentioned, the old classification used to be talking about developmental or acquired deformities and conditions around teeth, specifically being mucogingival deformities. And among that list, the two primary ones that we're going to focus on that everybody is most aware of are gingival and soft tissue recession, which we'll talk about soft tissue grafting. But I think one that gets overlooked far too often, but is another mucogingival deformity that makes a huge impact, are the frenum and muscle position and the movement and the effect that that has. So we're going to mention that as well. Etiologically, there's a couple different factors that contribute to these mucogingival deformities. As we mentioned, plaque and bacteria is always the case, and frenum, which I just talked about. Our toothbrushing technique and other things like orthodontic therapy make a huge impact. Believe it or not, from an ortho standpoint, if a patient is going through ortho movement, if you were to tip a tooth buccally, that would actually increase the amount of recession and make that attachment go apically. And conversely, if you were actually tilting a tooth to the lingual side, that would actually bring up that attachment to the coronal side. So you can actually increase coverage by moving a teeth lingually. Traumatic habits, we'll discuss that in a few slides here. Our biological phenotype, that thicker scallop versus, the thicker flat versus the thin scallop, and the difference that can make can leave you more predisposed to having recession. And malalignment of teeth and or a shallow vestibule, again, kind of following along that ortho topic, and again, just malalignment in general. If your teeth are overlapping, that can definitely lead to some of these deformities and defects. All in all, regardless of what the situation might be, our goals of therapy are pretty common, where we're basically doing two different things. Number one, we're trying to increase the amount and thickness of the attached gingiva. That always gets overlooked. Everybody's always focused on number two, which is root coverage, which, yes, is always important, but it's actually, I would argue, and I tell my patients all the time, that increasing the amount and thickness of that attached gingiva is as, if not even more important than the root coverage itself. For patients that have sensitivity, of course, we're trying to do that in the process of root coverage to reduce that sensitivity and eliminate the chance of having root decay. And of course, the aesthetic standpoint is always going to be one of those primary goals of therapy. Now, believe it or not, we're going to focus on those soft tissue procedures. It's kind of the traditional, the most tried and true and tested way of getting this type of treatment done. But that being said, technically speaking, there are a lot of different ways that you can treat root recession and root exposure. So not only from that left side that we're familiar with, can we do the soft tissue, free gingival or connective tissue grafting that we're going to discuss, but you technically can use a membrane. In the process of GTR, a membrane can be used over a recession defect and achieve root coverage. So not everybody is aware of it. The reason we don't use that on a regular basis is because soft tissue in comparison tends to be better, but it is still an option. And of course, biologics, which we'll touch on as we go forward, and some different techniques with coronally positioned or pedicle flaps of your existing tissue can also be an alternative that can be done. Regardless of what we choose, we always have to question the need of potentially having a frenectomy prior to grafting. And we talked about that already, and we're going to emphasize again why it's so important. Now, it might just be a very, very minor tug from the frenum attachment, but believe it or not, every time you talk, chew, and move your lips around, that kind of very low grade but consistent and constant tug that's creating, that apical pull that you get on the margin when there is a high frenum attachment, can with time create a further recession defect around a tooth that already has it, or it can cause it all by itself. So as a result of that, that can become a huge factor that gets overlooked, and that directly results in the failure of tissue grafting when that frenum attachment is not released as part of our overall treatment. So one of the main questions become, well, how do we know when we have a frenum pull issue? What is a good way and a good trick of us being able to determine whether it's on the mandible or on that maxillary anterior side? What is a good way of knowing? And the best trick to keep in mind for everybody as a take-home message is to look for marginal gingival blanching. So what we mean by that, whether it is your top or your lower lip, if I was to grab your lip and pull outward, and you were to see that the area where that frenum attaches near the gingival margin causes blanching around that gingival margin, that will be a good clue for you that that frenum attachment is so high up that it actually is going to be requiring release to prevent any further apical movement. So that's a very good and easy trick that you can use at all time. Now, the good news is treating this type of an issue is extremely quick and very easy via a frenectomy. We simply make a diamond-shaped incision at that frenum attachment and can release that frenum pull entirely. Now, whether you do that with a classic 15 blade or you decide to use a laser, of course, both options completely work. Just know that regardless of what you do, that frenum attachment is going to be something very important and something, if required, you're going to want to do before you ever do any kind of soft tissue grafting by itself. Now, we talked a little bit about traumatic habits, and what do we mean by that? Things like tongue rings, habits with toothpicks or pencils. You think of the days when we were in school and you always have that pen in your mouth, and maybe there's a resting place it always might be, or patients that have different appliances. You have a partial denture with one of those clasps that's sitting around the tooth and sitting right up against that gingival margin. All of those are examples. In fact, those pictures on the right side were both patients of mine. You can see on the upper right, that radiograph, that significant amount of lucency and mobility that my patient had, which came as a result of years of having a tongue ring and constantly using that tongue ring on the lingual side of those teeth. And on that bottom right, you can see that clefting that's happened between that canine and premolar, specifically from the habit of always having a pen in this patient's mouth for years of being in school, and kind of that being their habit that they always had. So again, these traumatic habits can create these mucogingival defects and deformities, so important to keep that in mind during your etiology. Now, regardless of what has caused the recession, a big thing that needs to be understood, and again is oftentimes overlooked, is what is our realistic expectation in terms of treating this root recession? A lot of people have the idea that any tooth that has recession can be grafted, and that is absolutely not true in terms of getting a good type of root coverage result. So if we look at kind of a basic classification of recession, they've got multiple different classes. And in a class 1 recession, the soft tissue will remain coronal to that mucogingival junction, and we have no bone loss. In that situation, we can with very good confidence know that 100% root coverage can in fact be achieved. That is our ideal situation. Perfect bone, soft tissue coronal to that mucogingival junction. We are in good shape of getting full root coverage. Now, in a class 2 recession, that soft tissue will progress either to the mucogingival junction or more apical to it. However, as long as our bone is still completely in ideal position, we have zero bone loss of any kind, we can still very confidently plan on being able to aim for 100% root coverage. So again, the bone level is what makes things the most important. As they always say, the tissue might be the issue, but the bone sets the tone. It's when we get into class 3 recession where we still have that mucogingival junction, that soft tissue extending at or beyond it. But what ends up happening in this situation is when we first start seeing signs of bone loss. And if it doesn't matter if that bone loss is 0.2 millimeters of bone loss or 1 millimeter of bone loss. The bottom line take-home message for everybody is, as long as you have some bone loss occurring around a tooth, 100% root coverage is no longer attainable. It is physically, by biological standpoints, impossible to achieve. Really important to point out, I can't tell you how many times patients get referred my way with some amount of bone loss, and the patient's expectation is, I'm here to get this entire root area covered, and that is just simply impossible to do. So keep that in mind. Again, 100% root coverage is not possible. And of course, the worst situation, which of course we would never want to treat, class 4, we've got tons of soft tissue and hard tissue combination defects. Of course, while that picture is a little bit sad right now, considering what just happened on the news, but I promise you that slide was there before. That is an abandoned ship, though. That is a situation that is not going to be successful. Now, I did touch real quick upon biologics, and biologics have become a huge thing, mainly within hard tissue augmentation, but it has been used for soft tissue augmentation as well. We are now capable of drawing a patient's blood and using a centrifuge to separate their platelet areas and get growth factors from there to enhance hard tissue healing. But we can also mix that with some of our soft tissue to enhance the overall healing time and overall result that we get as well. But probably the most popular and well-known of a biologic that helps with soft tissue is Emdogain. Now, Emdogain is an enamel matrix complex of proteins, and basically what it ends up doing is that it is tricking our body into thinking that the natural tooth formation is going to be going on and happening. And by doing that, by mimicking the biologic process of natural tooth development, it will result in regeneration that occurs. And we'll show you one case in which we show the use of Emdogain. So again, we want to talk about what are the most common soft tissue options that exist. And the ones that, of course, everybody has heard of are pre-gingival grafts and connective tissue grafts. They're kind of the bread and butter, tried and true formulas that we use. And we want to talk about one alternative material, which some people might be familiar with, called alloderm. And we'll talk about that and how it can be both a pro and potentially an added challenge for us. So we're going to go through those examples right now. Now, the free gingival graft has been around for a really long time. In fact, it was introduced originally back in 1966. And the classic article that started introducing this within the perio literature was by Sullivan and Atkins in 1968. Now, in order for a free gingival graft to heal, the single most important thing is that that graft has to be completely immobile. We need to have excellent hemostasis, and that graft cannot move. So many times patients wonder, or sometimes other colleagues will comment, gosh, do you have enough sutures there? Why do you have so many? And it is for this exact reason. Without excellent hemostasis and any kind of mobility, that graft will fail. Now, the free gingival graft is the graft famously also known as the tire patch graft. And you're going to see why in a moment. Now, if our goal in our mucogingival deformity case is to have an increased zone of attached gingiva, if we have an area that is all mucosa and we're trying to reestablish some very good attachment. There is no better source and no better technique to achieve that than doing a free gingival graft. Now, that process will involve removing not only the connective tissue layer underneath the area from the palate that we're working on, but as well the outer epithelial layer as well. That is why the free gingival graft technique causes so much post-op discomfort for the patient, because the entire site is going to be exposed, not just the inner connective tissue, which we'll talk about with the CTG, but the outer epithelium as well. Once we have that graft, we're now able to go around the tooth area, and by a series of different suturing techniques, with which there are various options, we're going to be able to get that graft to stay in place and hold and get that type of hemostasis that we're looking for. Now, this is a textbook example. You can see on that upper left, we've got that big frenum pull. The good thing with a free gingival graft technique from a surgical standpoint is if we also do have a frenum pull, we can address that and do the frenectomy with the free gingival graft at the same simultaneous visit. That is completely different than the connective tissue graft, where those visits are ideally going to be separated into two different parts. But you can see in both of these examples, the lack of tissue we started with and the very nice thick tissue that we ended with. Here's a clinical example from a patient of mine. Here again, you can see this would be, again, that lack of attached tissue, very common on those mandibular anterior incisors, very thin tissue there. You can see the bed that we have to create with the split thickness flap in order to create the spot for where that soft tissue will sit. We'll have to de-epithelialize the epithelium around the area where that free gingival graft will sit. And then you can see with that piece of tissue intact, by a series of interrupted, and in this case, mattress sutures, we're able to achieve the excellent hemostasis that we want. And here you can see why we call it the tire patch graft. You can see you've got a very nice thick band of attached tissue that is now sitting there. To show you yet one more example, and this one to bring in the biologics we talked about, and this is more of a step-by-step, we make sure that that root surface is completely cleaned off, no debris, no plaque, no staining of any kind. We also have to make sure that we are only touching the exposed root. You never flap the area and then scale the area below the existing recession where you started. Here you can see our flap design in this case with this tremendous amount of exposed root and very thin amount of tissue where you could even trace the outline of the root underneath. There you can see now our bed that has been created, as we say. And we've now got a nice area for that free gingival graft to sit. And there is the epithelium that we are going to de-epithelialize. So when that tissue sits over that area, we cannot have that connective tissue and outer epithelium of that graft sitting on an area of existing epithelium. That's why we have to de-epithelialize. And then any excess mucosal tissue is now removed at the base. And you can see we can now go over to our donor site. And in our donor site, the way we are able to do this is we can take a little piece of foil from the actual wrapper of our 15 blade, and we can literally trace the size that we want on the palate. So once we use our little piece of foil as kind of like an outline, we can put that on the patient's palate, and we can literally trace the size of the graft that we want to take from the donor. And there you can see once we get that graft out, we're able to measure the thickness of it to make sure we have at least the proper amount of thickness, a good at least 2 millimeters of tissue thickness there as a bare minimum. We use our 15 blade. Here you can see with that graft removed. We can now modify the graft to make sure that we have a graft that is not too thin, but is also not too thick. And we want to make sure distance-wise, we've got the proper length to fit the area that we want to work with. So anytime we feel like we need to make adjustments, we can use our 15 blade and go back and do the proper amount of trimming. For those of you who are interested in a second career as a sushi chef, this is a great way to start. Now we can see that graft in position, and then once it's there, we can see if we want to make any more adjustments. We can look on that left side and see we still have a little bit of excess, so we can trim that off. But once we do that, more or less, we've got a nice bed that is covered and inclusive, covering that exposed root surface on that tooth number 24. Now is where those biologics come in. We talked about M-Degain as an option. Well, we can put this M-Degain material now over that root surface as well to give us an added layer of biologic support in order of trying to get the best amount of root coverage possible. So we've got our Pref Gel and our M-Degain, Pref Gel being EDTA and our M-Degain material. And now you can see with that soft tissue in place, we're now doing our combination suturing between our interrupted and our mattress. You can see at each point on the papilla and on the sides. And then again, the sling there that you're seeing, that sling matches for stabilization. So a lot of sutures in place for the goal of immobilizing this graft as much as possible. And from a start to a finish, you can see by 2 weeks the amount of thickness that we've gotten. And you can see from where we started, from 2 weeks there, and now you can see at 6 weeks, we've got this massively thick amount of tissue plus root coverage that we've achieved. And for the patients, we always ask them if there's any situation where either for aesthetics or feel that we almost feel like we've made it too bulky, the option is always there, though not necessary, that we can go back with a diamond burr and basically smoothen out the extra thickness. Now, I rarely ever need to do that because this is usually not an aesthetic case, but that is an option there if you need it. So that is the pregingival graft in a nutshell. Our other option is to do a connective tissue graft. This was introduced by Langer and Kalanga in the mid-80s, and this is now kind of considered to be, in terms of root coverage, the gold standard because of the reasons of not only getting an excellent aesthetic result, but also because of the lack of discomfort from the patient side on that donor side on the palate. Now, in terms of different techniques from a surgical standpoint, we're not going to go through all of them, but suffice it to say, there are many, many different techniques in terms of flap design. We'll just show you examples of 1 or 2 of them. But the bottom line with the CTG in comparison, as we mentioned, quicker healing, much less painful, better aesthetics. And the beauty about this graft is that if there are some areas of exposure, it can still completely heal. And we'll talk about how that is very different from our alloderm material. So as you can see, both from the donor side and from the area where it goes, on our donor side on the left, because that tissue is being taken from within the palate, that outer epithelium is left intact. This is why, compared to the free gingival graft, the patient doesn't have that pain, that post-op discomfort that is so common that you hear about in the free gingival graft. Now, as also mentioned, with the connective tissue graft, when you do cover the area, if there do happen to be small amounts of tissue that are still exposed over the root surface, that is completely okay. As long as the majority of that graft has been covered and has blood supply, even small areas of exposure are 100% fine and can heal and give you complete root coverage. So it gives you a lot of flexibility with this technique. So like I said, there are endless different techniques and examples. Here's some around these premolars using the classic Langer technique, who first created the graft itself. You can see with that connective tissue over that area, we can use simple interrupted sutures to put that graft in position and then close that flap right over that site and achieve complete root coverage. So that is one option. And here's another example of the same thing with the exact same technique. The classic Langer technique there. You can see both of those premolars, the graft there in position, and you can see from start to finish that increased amount of root coverage that we achieved and we were able to get. Now, other techniques that exist, one thing that we can do, assuming that we have a good enough base of attached tissue to begin with, is we could do something known as a tunnel technique, where we're able to, without raising a flap and raising the papilla, create a tunnel from underneath the papilla and all those areas. And you can see we can even stick our probe there so we can get our tissue slide it into this tunnel and then suture things in place to get our root coverage. So you can see the area on the palate and how you have no outer epithelial exposure. There's no tire patch there for the patient to have discomfort over. You can see that connective tissue on the outside, and then we can slide it into our tunnel. And then whether it be with sutures, or I show this case as another example of some people, and this was a case of ours, that we use cyanoacrylate, being basically a glue in the mouth that will help secure that graft into position. That is another option that you have, and another example of how these types of grafts can be done. Here is another example of that same tunnel. You can see in this case not only a significant amount of root recession, but you've got some abrasion there. And you can see another tunnel has been created around that site. You can see the graft on the outside, and you can see what that graft looks like once it is slid in. Now, this one, a few weeks after healing, we got the glue over the top. This one, we did not get that full amount of exposure. And again, important to show, not every single case are you going to get 100% exposure, and it wouldn't be realistic to show every case as if it has a perfect ending. That's just not how dentistry works. But still, in this case, considering where we had started, we have a significant amount of more attachment gain. The sensitivity the patient was having was no longer present, and we've got a much improved overall result. Now, one thing that gets overlooked that I do want to point out is that even though we use the patient's palate to grab the tissue, regardless of what type of graft technique we use, we don't have an endless amount of tissue to work with. Not only are patients limited on how much tissue they have, but at the same time, depending on the actual length and depth of their palatal vault, we are actually limited onto how much tissue we can even harvest to begin with. So this classic perio article by Reeser in '96 showed that we have to take into account that whether the patient has a high, average, or shallow palate, not only do we always have to keep a few millimeters away from the CEJ on the palatal side of those maxillary teeth, but knowing that we have our greater palatine artery and nerve at that base area, especially around that molar, first to second molar space, we only get a limited range of space of where we can work with to remove the soft tissue. So in areas where our patient either has an average or especially a case with a shallow palate, we might be limited, or to the point we may not be able to use that patient's palate altogether to get this sufficient amount of tissue that we need. So it is important to keep in mind that in some situations, the patient's palate may not be an option. And it is for that reason that having an alternative material that we're going to discuss momentarily is going to be so important. So overall, for our mucocongenital checklist, the essentials, again, we need to make sure we have proper amount of attached tissue versus mucosa in order to determine what type of technique we're going to use, what type of graft we're going to harvest. The periodontal biotype plays into that as well. We discussed how using something like a tunnel technique, for example, requires us to have very thick tissue as a starting point. We talked about the importance of the Frenum pull. The patient sensitivity. Sometimes, of course, patients may have rampant recession but have no sensitivity at all. Parafunctional habits, and again, all of that will assess the overall treatment plan based on what other type of restorative or prosthetic work or orthodontic therapy the patient may or may not have. So keep in mind with ortho, we just did a big webinar on this not too long ago. With ortho, again, very important. If you have no attachment to begin with and you're planning on doing orthodontic therapy, grafting on the front end is going to be very essential to do. However, if you do already have very good attachment and soft tissue and you're going to be doing orthotherapy, any soft tissue grafting that needs to be done can be done after that therapy is completed. So we talked about the importance of the two options that we had and in terms of grafting options, and we talked about how with connective tissue, you cannot have the area be exposed if you don't have good blood supply. Well, this is where this all comes home, is with this alternative material known as alloderm. So let's just say we have a situation where we have that area where on our palate, we don't have a big enough area to harvest. Or maybe we have a big enough area, but there are so many different teeth in a row that need to be grafted that we just don't have enough length. Well, that's where this material comes into play. Now, Alloderm, believe it or not, is actually based off of and comes from cadaver skin. It is an actual dehydrated sheet of tissue of cadaver skin. The beauty of Alloderm, as you can see, is that we can have as much material as we want. So we are not limited on the supply and the amount like we are with the free gingival or connective tissue graft. Where things become very different, though, I showed you with a connective tissue graft how if you do have a small amount of exposure at the time of suturing it, as long as you've got good blood supply, you're in good shape. But with Alloderm, the technique is far more sensitive. And even just a small corner of exposure of Alloderm during the suturing and the healing process, if just a small amount of it do become exposed, it can actually result in the failure of the entire graft area. So the suturing technique and the case selection to decide to use this material is far more important. Here, just showing one example in terms of suturing, where you can see there is not even a glimmer of graft exposure present. And this is the type of closure that you're going to require in order to be very confident with an Alloderm material. So a little bit riskier in terms of that, a little bit more important from a case selection standpoint. In comparison to connective tissue over the long term, our own connective tissue is still going to be better than Alloderm in terms of long-term results. However, in terms of having an alternative that is still very effective, and for those patients who are just too terrified or flat out refuse to use their own soft tissue, it does give us another option. That's why it's important to point out, and I wanted to demonstrate what that is and how it works. So on natural teeth, depending on what the type of defect is, our basic decision tree, if our main concern is lack of attachment in a thin biotype, our go-to is always going to be a free gingival graft as our primary choice. If we have the situation where we've got recession with some level of attachment and we've got a thick biotype, then we can really rely more on the connective tissue graft. Although, again, all the different options that we mentioned up until this point are always available to us. Last but not least, if we have some recession and some attachment with the thick biotype and sensitivity is not an issue, again, not only can we still graft the area via connective tissue graft, but keep in mind, sometimes our options are going to be no treatment at all. If the patient has no sensitivity, it's not an aesthetic concern, and they would rather go an alternative route. We're going to show you in our last part of the lecture, 2 different great alternatives that we can have to that. So with that being said, I did want to spend a few minutes talking about soft tissue around implants. Again, we do focus around teeth, but the importance of them around the implants and our long-term implant success is also being overlooked. So really important, and we're going to spend a few minutes talking about that right now as well. So to basically summarize, the difference between natural teeth and implants traditionally is that the connective tissue attachment around a natural tooth and implant have always differed. The connective tissue around implants, rather than being in a perpendicular fashion like it is with natural teeth, are actually in a parallel type of position. And due to that parallel position that they are in, the parallel attachment that they have, that makes them significantly more prone to inflammation. They have a lack of vascular supply. And again, that makes these implants far more permeable and susceptible to bone loss and inflammation. So that is a very big difference between teeth and implants. Now, part of that challenge was actually solved by BioHorizons, because they came out with an implant with a specific engineered surface known as laser lock, which was the first implant, and really up until now, the only one that created a exact same situation as natural teeth had, where the connective tissue, when we looked at it in terms of a histological standpoint, we're actually creating a perpendicular attachment around the implants, the same as they were around the natural teeth. This was pretty revolutionary when this first came out. This has continued to be pretty revolutionary. But take-home message is, unless you're using this special laser lock surface from this company, BioHorizons, The majority of implants that are out there, again, they create a more parallel type of attachment rather than perpendicular. And again, that makes them more susceptible to having inflammation and bone loss long term. Now, when we talk about soft tissue complications around implants, the three primary things we focus on, again, a lack of attached tissue, similar to what we talked about with teeth. Volume deficiency, meaning that you might have some soft tissue, but just not a very thick amount. And then recession that we see around implants, which again is a nightmare situation that can occur. Now, the stats tell us that almost 3 out of every 4 implants that are placed in an area that already has a lack of attached tissue at baseline. That, of course, you can now appreciate more, results in disastrous long-term issues. And one of the big reasons why peri-implantitis is on the rise and is exponentially rising is not only because we're placing so many more and not everybody is at the same level at their placement. However, it's also because, again, of this stat here, where the majority of these implants are being placed irrespective of the soft tissue that they're being placed at baseline. And what we found is that for immediate implants, advanced recession has been very common, and greater than 1 millimeter of midfacial soft tissue recession in these immediate implant cases have been reported in over 60% of implant cases. And this is from Thoma's article just about a year and change ago. So this problem is rampant, and again, something that needs to be addressed. So a couple different options that we have. When we think about attached tissue, we're all aware of what that is and what that stands for now. And the result of what happens when we have a lack of attached tissue on our implants, we get a greater amount of plaque accumulation, inflammation, and again, that can also lead to some patient discomfort. With volume, like we talked about, we're really looking more at overall thickness. And we're trying to know that if we've got more thickness on that area, not only is that going to be better from an aesthetic standpoint, but having a better overall volume is also going to prevent that bacterial accumulation and that marginal bone loss that we get. So the thicker our tissue is, the better off we are as well. So what are our options? How are we going to go about treating this? And more importantly, when is the right time to have this be treated? Well, first things first, for soft tissue management, our options are either to address it before the implant has ever been placed, during the implant placement, simultaneously, during the healing phase between the placement and the abutment connection time, simultaneously with the abutment, or after the implant has already been delivered, the final crown and prosthetics. So we're going to go through our 3 situations and see when we're going to favor what. Well, I can give you away already one of the answers, and that's going to be that trying to address the soft tissue around an implant after it has already been restored. The abutment and the final crown are already there, and we decide, okay, let's try and do something about the soft tissue. Doing it at that time is the absolute worst choice we can possibly make. Our ability to achieve very good root coverage and overall improved aesthetics and increased tissue thickness, once that implant is already in place, our chances again are going to be significantly worse. You can see in this article, none of the sites were able to get a complete dehiscence coverage tissue by doing grafting in that site. So for areas when we have the situation of lack of attached tissue, our ideal times to do this are going to be before the implant is ever placed. If you know you're planning an implant for your patient and you know that site does not have good attachment, the best thing you can do for yourself is to go for our techniques that we talked about, whether it's free gingival, connective tissue, or alloderm, and do that before the implant is ever placed. If that is not an option, the best time after that to do it is going to be during the healing phase at the time of the healing abutment placement. So basically think about your implant uncovery. We're going to show a case or two of an example of that to demonstrate. Now, if we're talking about a lack of volume, we have some attachment, we just want to make it thicker. Well, in that case, we've got a lot more options. We can do it before the implant has been placed. We can do it during an immediate implant placement, or even during that healing time. The reason we have more options with this situation is because we already have an existing baseline of attachment. We're just trying to make that existing base of attachment a little bit thicker. So that gives us a lot more flexibility. And as we mentioned, when it deals with recession, because of the fact that the tooth has already been restored, well, obviously the only time that we can treat it at that point is once that abutment has already been put on by definition. But as we mentioned, that is going to be a much bigger challenge. Here by that article, they said that they were getting a very high percentage, but again, the reality, and I can tell you this from clinical experience, once that has already been at that prosthetic phase, our chances of really getting predictable outcomes with this are much lower. It is a very unpredictable type of process. So here's a summary of what we talked about on a scale from start to finish. Before the implant is placed is the ideal time for volume and overall augmentation. During the implant healing phase, just the same. And the situation we're trying to avoid, if it could all be possible, is after that crown has been delivered. We want to do things at the best time, and the green before implant or during that implant healing phase tend to be our best 1-2 combination. So these are examples of doing it during the abutment time. So you can see we have a situation where we're doing an implant uncovering. We've determined, hey, you know what, we could really use some more soft tissue. And at that implant uncovering time, we can put the healing abutment on and add some attached tissue to get the increased thickness. Here's an example of a patient of mine who had 3 implants placed on that lower right side. They also went through a significant amount of bone augmentation, which as a result of doing the massive bone augmentation, brought their mucogingival junction very coronally. So what started with great attachment ended up with very little. You can see during the implant healing phase, we can already appreciate the fact that the majority of that buccal area is going to have a lot of mucosa, and we're wanting to make that area thicker. So what we basically did at the time of the implant uncovery is that we created that same bed for our free gingival graft. We went to our palate, and as you can see with this patient with a shallower palatal vault, even though we were able to get a very long piece, we weren't able to get a very wide piece, again, because of our concern with that palatal vault and the overall location of the nerve and the artery. So you can see now with that free gingival graft in position, and then after the site had healed, you can now see that we have achieved a nice little band of attachment. And what might not seem like much on that photo, believe me, from a clinical and long-term stability, anti-inflammation, and antibacterial accumulation around those 3 implants, this result is going to be something that we are very, very happy with. So again, with implants, slightly different than teeth, our decision tree is slightly different. If we have just bottom line a lack of attachment, that free gingival graft is our go-to. If we either have a lack of attachment and a thread exposure on top, once again, the free gingival graft, because of that increased thickness, is going to be the way to go. However, if we have just a very minor thread exposure with or without attachment, even though the free gingival graft will still work, that does open the door for us slightly with doing the connective tissue. Alloderm implants is technically an option, but again, because of the challenges that we discussed with that amount of root coverage that we need, again, our own tissue is still going to be the preferred way to go. So we've gone through some of those clinical examples. We just want to talk a little bit about home care and wrap it up with our alternative options with the remainder of our presentation. From a home care standpoint, I always highlight for my patients the most basic thing. What type of toothbrush are you using? And as we all know, all of us tended to brush our teeth too aggressively. What we've been taught when we were younger was to get a firm brush and to scrub and go to town. We've now learned over the years that that is actually creating recession, and that's the worst thing to do. It is traumatizing the gingiva around our teeth. And now we've been recommending getting the softest brush and being as gentle as possible. Well, patients ask all the time, how do I know whether or not I'm being gentle or not? And the short answer to that is with this IO brush, it has artificial intelligence that will tell you while you are brushing your teeth whether or not you are doing it with the proper amount of pressure too aggressively, or you're doing it too soft. So that very simple green, red, and light blue light that it has will let you know how you're doing. So this real-time feedback goes a really long way for your patients in educating them and having them understand that they're not brushing too aggressively and too hard. Now, of course, for somebody like me, having them not brush too hard, there's less recession, there's less treatment to do. But obviously, jokes aside, this is going to go a long way in preventing a lot of these types of recession defects that we see. Now, to wrap up, we talked about different examples, and here's yet another example of a tunnel with a graft. You can see those 3 teeth in a row with recession. We've created a tunnel, we've put our graft within that tunnel, and now we've also gone out of our way to suture things in place without ever having to flap the area. And you can see we've been able to achieve great root coverage and have a great result. However, as much as everybody loves to do connective tissue and free gingival grafts, of course, some patients are terrified and or flat out don't want to do that. So we want to talk about some non-surgical alternatives that can exist to treat these areas. So we're going to go over 2. One that deals from an aesthetic standpoint, an alternative, and one that deals from a sensitivity standpoint and what we can do. So talking about these non-surgical alternatives. And from the aesthetic standpoint, we're going to talk about a product from our friends at Shofu. Now, we're all familiar, the alternative, if we're not going to do soft tissue from a perio standpoint, the most popular option has always been to do a class 5 composite, right? Now, a class 5 composite can be very beneficial because not only are we covering the area that's exposed, and for a patient that might be having sensitivity, that can take that sensitivity away. At the same time, it provides that fluoride release and to help prevent any kind of decay around that area, and it gives patients an alternative to having to do the soft tissue. However, what happens so many times with these class 5 composite restorations, like this one you can see pictured here, is that aesthetically it doesn't look too great. It stands out and is very noticeable. In addition to that, as a result of that white color with time, with just natural wear and use, it's very common for those to start getting some staining around there, and then it stands out even more. So the question that Shofu wanted to answer was, can we create something that is going to be more aesthetically pleasing and still incorporate this class 5 type composite technology? And that is what they did with a product they made called Beautiful Gingiva. Very creative with the name, to put it mildly. But as you can see, what they have created is essentially pink composite. And they have multiple different shades that you can see. And instead of putting a class 5 white composite that is going to stand out and be very obvious, they now have a pink composite that can go and be a much better aesthetic match around the teeth. So we're going to show you examples of this. So the process for doing it and using their product is going to be the exact same as any other type of composite that we've seen on the market and are used to using. You can see these old composites that have been removed. You still go through the same kind of etching and bonding process, but you can see with their pink composite in place, again, from an aesthetic standpoint, you have a class 5 composite in that area, but because of the pink, it looks obviously a lot more like the patient's natural gingiva. So from an aesthetic standpoint, this gives you a very good alternative to patients, again, that aren't looking to use a typical class 5 kind of tooth colored composite. Now we've got this pink one in place that can really make a very big difference. But we have situations where patients don't even want to have the class 5 composite. They're coming in and basically saying, look, I'm not worried about the aesthetics. It's not something that's visible to me or something that I care about, but it is very sensitive and the sensitivity is driving me nuts. Is there any option that we have? And that we have from our friends and sponsors from Voco. We want to talk about the different type of varnishes that they have. Now, when we talk about the very well-known and very kind of widely respected and studied Voco varnishes that are out there, we know the official indications for use are going to be for this desensitization that we discussed. treatment of these exposed root surfaces, and any kind of cervical or enamel defect. However, off-label, they also do provide a very good amount of fluoridation. That's very important to point out because, again, a lot of these traditional varnishes that are out there, they don't always offer the fluoridation. And of course, from an anti-decay standpoint, we want to make sure that we're still able to provide something that can be a solution for that. So their varnishes do that. Now, according to what the ADA says, again, they've pointed out that fluoride varnish is effective in preventing decay. So we do know that for as a fact from the ADA, and we also know that fluoride varnishes not only take less time, but of course they create less patient discomfort and give you greater patient acceptability compared to gels. So it gives us a good alternative option. And of course, if we're going to compare this to doing a connective tissue or a free gingival graft for the patients that are a little apprehensive for it, it's great to know that we have this option. Now, there are multiple different options that Voco has in terms of fluoride varnishes, and we're going to go through a couple of them. One of them is called Pro-Fluoride varnish, and you can see is a 5% transparent sodium fluoride varnish material. What's very good about all of their products is that they've got this high immediate fluoride release. A lot of different varnishes that are out there, the fluoride release is done at a much slower and more gradual pace. But with the Voco products, it is a very high concentration and immediate amount of release, which is why they are able to achieve such a good anti-sensitivity type of result and therapy for it. Also, what you'll see, and we'll talk a little bit about their single dose delivery system, which from a clinical side, for those of you who are applying this type of material, is just going to save you time and make your job that much easier. Now, we talked again about this fluoride uptake and how important it is. And when you compare it with something that we used to use in dental school all the time called Durafat and other type of solutions that are out there, again, you can see that immediate high amount of fluoride that is released in comparison to the other products. So it's very important to emphasize the fact that it is coming out at such a high pace in terms of providing a immediate and quicker, again, anti-sensitivity and the overall discomfort. Now, they have another product that gives you even a prolonged amount of protection and desensitization, known as Pro-Fluoride L. The L essentially standing for the long lasting. So this is a synthetic resin. You can see the long-term desensitizing has been found to be upwards of 6 months of time, which is pretty awesome to get from just that single dose. Again, very easy to apply, doesn't have any stickiness to it, and it has that same 5% sodium fluoride option there at the base. Last one I want to mention is another product they have known as Admira Protect. Now, this is a nano-filled resin, and again, in terms of wear, it is very good for overall wear resistance, and this has been found to eliminate sensitivity for up to 2 years. So we've got multiple products within the Voco family that are providing us a very tremendous amount of time in terms of overall anti-sensitivity treatment. And again, this, like all the other products, have that same patented single dose delivery system with that very good immediate high fluoride release. So what that single dose system will allow you to do, you're not going to have any of that stickiness. It is just a quick one-time placement. It makes you, again, like I said, it saves you a lot of chair time, and again, makes the overall process much quicker and much easier. So something worth pointing out. So at the end of the day, not only is it easy for us to use, but you even have the option with the single dose to give it to the patients to do at home. That's how straightforward it is. Your patient can literally follow the label on that and apply a little bit of that over their tooth surface if they wanted to at home. So again, a lot of options and a lot of flexibility. And this is a great product to have at the practice. Like I said, even for a situation that I have, for a patient that does not want to do a graft or any kind of composite, having that there gives us a very big advantage. Again, it has a white transparent color. You won't get that yellow discoloration that we get with a lot of those other composites, the classic tooth colored ones that we mentioned. And again, it sets very quickly as soon as it comes in contact with saliva. So a very quick and easy overall product and system to use. Great to know as another alternative for your patients. Last but not least, it does have xylitol. We know from an anti-decay standpoint how important xylitol has become. We've started putting it in all different types of chewing gum for the exact same reason. So high fluoride release, but also very good anti-decay properties. So with that being said, we went over a ton of information in a short period of time. Again, in conclusions, mucogingival deformities, they come in all different forms and have a lot of different ways to be treating them. It all depends on their radiographic and clinic presentation. Remember, any amount of bone loss around the teeth means 100% root coverage cannot be achieved. Make sure you maintain expectations both for yourself and your patients. As I've made a point, not only is soft tissue essential around natural teeth, but it is critical around dental implants as well. So do not overlook the importance of soft tissue there. As we now know, we've got non-surgical solutions that not only from a toothbrush standpoint can help reduce recession happening in the first place, but we've got some nice aesthetic pink, material that we can use that can also be an alternative. And last but not least, from our hosts at Voco, we've got a very simple single dose application with multiple different types of varnishes that are out there that are going to last a long time and also give us a great alternative form of treatment for our patients who don't want to go through that grafting process. So with that being said, again, we're just staying right on time. It gives us a few minutes to go over some questions. From the city of Boston, I want to thank everybody again for tuning in tonight on their Monday. Again, we had a ton of material to go through, so thank you for keeping up with the high pace. I will stick around to go over any questions you might have. For those of you interested as well, I'd love for you to keep in touch. Follow me on Instagram. There's the barcode there for you to scan and keep in touch with future upcoming lectures and events. And any other questions you might have. So again, I'll stick around. And again, thank you so much. All right, let's go back here. So a couple questions that are here. I'm going to go through the list here and see what I can find. So again, some questions here about soft tissue around implants. A couple from a different technique standpoint. One question being asked on the case I showed with the 3 implants, would it be possible to use alloderm with the pin tunnel technique during the osseointegration period? The answer to that is yes. Again, you can definitely use some soft tissue during the actual healing phase. That's one of our kind of green zone areas that we pointed out. In terms of techniques, again, there are different options. In general, talking about the tunneling technique, again, the most important thing for whatever type of surgical technique you go is that you've got the proper kind of baseline tissue to work with. So as we talked about with kind of a traditional tunnel technique, same kind of concern. A lot of times people opt to try tunneling in areas where they've got very little attachment and a lot of mucosa. And again, that is very difficult. It results in a lot of tearing and is very complicated to do. So you really want to make sure you're doing it at the time where you've got the best conditions. But if you do, by all means, you can. And again, alloderm is a material that can be used and it absolutely works. Again, it provides us a good alternative. So that can definitely be done. So next question, if there was decay only on the root surface, would you get rid of the decay and graft, or would you place a restoration and graft? Great question. One thing important to point with grafting, soft tissue grafting, is that you cannot put soft tissue over any kind of restorative material. Soft tissue can only be sitting on natural tooth structure, on, over not enamel, but over cementum, over root. So we can't put a restorative material on that root surface and then go back and try and cover it with soft tissue. So you would need to get rid of the decay and just graft over the root directly. Other questions here. So limitations in grafting for abfraction. So yes, again, it's definitely a bigger challenge when you've got these very significant amount of abfractions. Depending on the case, and again, the bone levels, yes, it is still possible to achieve some coverage, but in areas where you've got a very significant amount, those might be good situations where, again, you opt for doing a more restorative approach in terms of, again, covering the tooth with some type of restoration to deal with it more prosthetically instead, again, because of the challenges that you point out in your question with, heavy amounts of abfraction. Quick question here, a quick comment about root planing at the time of surgery. So again, when we talk about root planing, the biggest point is that you need to root plane the surface of the exposed root only. So what we mean by that is sometimes what happens is that people will flap the area and then they will go and start to scale the root surface. The problem with that is if you actually end up scaling part of the root that was originally covered by your own tissue, you are now going to damage the healthy attachment, and it is going to affect the result of your soft tissue graft attempt. So before you ever flap an area at all, that is when you're going to plane, scale and root plane the exposed root surface. In terms of doing any kind of detox of implant surfaces, good question as well. A lot of kind of questions and debate with that. There are some new materials out there. One that I highlight known as a Hybenex gel, which will kind of kill off some of the biofilm around the area, or even try an air polishing. In terms of a decontamination, that can definitely be done. But again, hopefully from an implant standpoint, you're addressing that soft tissue before that recession has ever occurred in the first place. So wanted to point that out. Last question here before I know I'm going over the time here. Do we ever use resorbable sutures? Absolutely, we do. In fact, for a lot of these areas, the majority of the time we use resorbable because we don't want to have the patient carrying around a suture material that lasts a longer time and it can accumulate more bacteria. So we do that. If it's a case where we really feel like we want something stronger, we make sure we have them back within that 2 weeks to do the suture removal. So I got through as much as I can right around that 8 o'clock time. So again, thanks so much for tuning in. We covered so much material, and keep in touch with me with any questions, and look forward to crossing paths again with everybody.